Hello, everyone. I'm Will. I worked in the past for Mind Aberystwyth, where I conducted what I believe was the first ever mental health archaeology project in Wales. And also more recently at MOLA, where I delivered some of the earliest developer-funded archaeology projects with other colleagues who are here today, but not in the room with us right now. See if you can catch up with Katrina Gargett and Aisha Purcell to find out a bit more on that. I was going to be presenting this with my brother, Robert Rathouse. Unfortunately, he couldn't make it here today. He's a senior occupational therapist in a psychiatric intensive care ward, and he was needed for work, unfortunately. So this paper proposes a couple of areas for future research, in particular, but let's just sort of look quickly at the background of this area, because really since 2012, projects using archaeology to support mental health have been run. First, you had Operation Nightingale and the Past in Mind. Since then, you've had a whole lot of other projects building on those foundations, including, of course, Human Henge, Mind Aberystwyth's War Memorial Survey, Waterloo Uncovered, the Older Londoners project I did with the Thames Discovery Programme, Curious Minds, the Well City Salisbury project from Wessex Archaeology, and many, many others. Projects have also been run overseas, as we have Operation Nightingale for veterans in the UK. So the US has American Veterans Archaeological Recovery, and there's been some really exciting work done with Indigenous communities in British Columbia by David Shape and his colleagues. But if we're going to talk about researching the effectiveness of these, we've got to talk a bit about evaluation. Now, we all expect that projects with receipt of grant funding and indeed developer funding are going to be evaluated. You have to demonstrate that you're providing value for money. Evaluation data comes in two principal forms. We've got the quantitative data, a numerical value, which is most useful in showing average change across a group. Its weakness, especially in small groups, is that it can be affected by other incidental experiences people are exposed to. We can't sort of separate out the effects purely from what we're doing in isolation from everything else in a participant's life. Qualitative data, on the other hand, comes in words and includes narrative data which can demonstrate the reasons why effects are experienced. I would argue that a robust evaluation process ought to include both kinds of data. Quantitative data can be gathered using a wide variety of means. I've come across at least half a dozen in my time. The UCL Museum Wellbeing Measures Toolkit uses a particularly good visual interface in which respondents circle a number in the coloured umbrella that you can see on the left there. Right, sorry, right, my left. However, that system is seldom used outside of the heritage sector. And I feel it's very important to be able to cross-compare what we're doing in the heritage sector with what other people are doing in other areas. And for that reason, I've tended to favour the shorter Warwick-Edinburgh mental wellbeing scale on the left-hand side, which is used across a wide range of projects in many different sectors. Qualitative data can be gathered orally or in writing and could be presented in a number of ways. We've got a little word cloud in the middle that's one way of presenting that data. I would argue it's very important to formulate questions used in qualitative research very carefully and to really encourage the participants to be as critical as they can be. For example, in the War Memorial Survey, we really wanted people to tell us how things could be done better. And we got responses including, in terms of how the project could be improved, I feel further outreaching to prospective participants would help. Many of those who joined us towards the end of the project expressed regret at having not come aboard sooner. And I feel there are others among my Aberystwyth's clients who would feel the same way. So please do, if you're designing your evaluations, please encourage criticism. Now, this is where my brother was going to really shine. One of the things I think we need to address a little bit is the extent to which the diagnosis might predict how effective a heritage activity might be in improving mental health. There are, of course, a wide range of mental health conditions. I've listed a few here. Government figures from the National Institute of Health state the most common conditions are depression, anxiety, panic disorders, obsessive compulsive disorder, and post-traumatic stress disorder. Now, over here, I've sort of divided things up into mood disorders, which are diagnosed when feelings and emotions become out of control and start to impact seriously on a person's ability to live a comfortable and fulfilling life. Perception disorders involve false sensory input, for example, hearing voices or seeing things that aren't there, i.e. audio or visual hallucinations, and or problematic ideas or beliefs, for example, a sense of being watched or that people are out to harm you. Some disorders involve both perception and mood problems, for example, bipolar disorder and body dysmorphia. Other problems affecting the mind can also include dementia, learning difficulties, addictions, obsessive compulsion, and autism spectrum neurodivergence. I haven't got time to talk about each individual listed condition, but I would recommend reading the Mind website via the link shown over there to get some more details on those different diagnosed conditions. So we're also interested in how severity of conditions might affect outcomes, or also how we run projects seeking to address those conditions. So we'll just go through this graphic quickly here. You can see that stage 1 or level 1 mental health condition doesn't demonstrate a great impact, but does display identifiable signs of problems. Stage 2 involves regular symptoms which do interfere with activities and roles of daily life. Stage 3 involves serious disruption to a person's life. And stage 4 involves persistent severe symptoms which may cause the person's life to become at risk. In rare circumstances, the person may also present a risk to others. Which leads me neatly on to talk about how people's attitudes to mental health have really need to be reconsidered in some cases. The Time to Change Attitudes to Mental Health Illness research report, which is available online, showed that over a third of British people assumed that people with mental health problems were likely to be violent. In actual fact, research has shown that people with poor mental health have been shown to be at greater risk of being victims rather than perpetrators of violence. In particular, the largest danger to people living with mental health conditions is that of suicide. It's far more prevalent within that demographic of people living with poor mental health. Which leads us on to consider how the projects that we run with seeking to improve mental health through heritage interaction can go wrong. In what ways might our projects end up doing more harm than good? One concern is that the participants' mental health could get worse. That is, they could sustain psychological harm from their experience. Now, one way in which this could happen is in a post-project downturn. Now, this was explained to me by Dermot Walsh, who was one of the original people in Operation Nightingale. He explained that people had been taken out of profoundly distressing situations and put into these fantastic projects where they were doing fulfilling work with like-minded people that was really supportive. But then at the end of the project, they were straight back where they started. And having experienced that way in which things could be better, to have that suddenly stripped away might actually cause them to be in a worse situation than they were when they started. In some cases, participants might find experiences associated with the project a bit too much, an overload, or aspects of it triggering. In the book on Operation Nightingale by Richard Osgood, he mentioned that the book's called Broken Pots Mending Lives, highly recommended. Richard Osgood remarks that contrary to the fears, some people on Operation Nightingale might have problems with excavating skeletons. And actually, this is something Dickie brought up to me as well. In actual fact, it wasn't the case. Dickie told me about a situation on the World War I battlefield of Bullecourt, where veterans and serving personnel actually kept vigil overnight with remains of a fallen soldier that they had found prior to that skeleton being excavated and taken for reburial. We've also brought out concerns that behaviours by some participants might be triggering for others. Now, I've never seen this happen on a heritage wellbeing project, but I was involved in an ecotherapy project in West Wales, where one participant decided it was an excellent opportunity for a bit of naked sunbathing, which would have caused problems for some of the other participants if my colleague hadn't caught him and persuaded him to get dressed again. So there's also other potential hazards. One thing that Dermot brought up again was dependence. He mentioned that he had seen some people going from project to project without gaining a great deal of more independence through participation. We want our projects really to be transformative. One accusation that has been levelled at community archaeology projects across the board is that it uses unpaid volunteer labour to do work that should be left for professionals, that is exploitative. The assumption is problematic on two bases. Firstly, community archaeology work almost invariably focuses on archaeological features that would not be investigated by paid professionals. There just isn't the funding. Secondly, the argument that archaeology should be left to professionals could be seen, or definitely is, in my opinion, exclusionary and as such problematic in and of itself. As archaeological sites can also present other hazards. I've worked on sites where asbestos has been present. Other sites have been exposed to raw, albeit diluted sewage, and animals likely to be vectors for diseases such as leptospirosis or Weil's disease. Some archaeological sites contain trip hazards and sharp objects. Working out of doors may also involve exposure to adverse weather conditions, where a mental health condition involves inclination to self-harm or risky activity, such as some personality disorders, body dysmorphia, to name but two. Extra care will also need to be taken to ensure that participants diagnosed with or believed to be prone to such conditions remain safe. So what are we doing about this? How are we addressing these concerns to make sure that the projects that we run are safe? Paul Everill and Karen Burnell undertook a research project jointly hosted by Winchester and Solent universities to identify best practice in heritage wellbeing projects. They conducted a consultative process with project organisers, participants, mental health specialists, and others. The Amphora guidelines that they produced present a robust and well thought out set of guidelines for running such projects, along with guidelines for people coming in as participants. We hope further research will assist in adding ideas to these guidelines that can further assist to ensure the best outcomes for participants. So in conclusion, when we design heritage wellbeing projects, we need to remember that people with the same diagnosis may present very different signs and symptoms, and that the same individual may present differently in different episodes of poor mental health. We hope to see more assessment of the needs of individuals participating in projects. We, of course, live in a time when mental health is in short supply. Wars, economic stress, coupled with rampant inequality and high unemployment, are strongly associated with poor mental health. Attitudes to mental health have indeed improved in the last few decades. Poor mental health is much less stigmatized than it was. However, promises to fund mental health care as well as physical health do not appear to have fully come to fruition, and more needs to be done. We believe that heritage-based activities are not a panacea, but we believe they can make a significant contribution to improving the situation for a great many people. We want to see more research being done to establish how best to tailor practices to cater for different conditions and severities, and to build a research base on the extent to which those conditions and severities might indicate outcomes for heritage-based interventions. Thank you all very much for listening. I'll hand back to Desi before we go for some questions and answers. Thank you.